Welcome to Rounds, everyone. Thanks for joining us today. Our first speaker is Dr. Luke Brueton-Campbell, who's one of our fifth-year residents in our Royal College Emergency Medicine program. And he'll be speaking to us today about updates in sepsis. Luke, thanks for speaking today, and I'll turn things over to you.
Perfect. Thanks, Rebecca. Good afternoon, everyone. Thanks for joining us on our grand rounds here today. So if we haven't met before, I'm Luke Brueton-Campbell. I'm one of the R5s in the five-year emergency medicine program. I'm also one of the sports medicine fellows at Pan Am at the moment. And today I'm going to be doing a presentation called Get Comfy, SOFA2 and Updates in Sepsis. So hopefully try to tie in some clinically useful pearls and kind of go through some of these big new updates that we can bring into practice. So our objectives today. So understand sort of the basics of sepsis 3, some of the definitions. We're going to go through and kind of understand the big changes that have been made between the SOFA and SOFA2 scores. We're going to go over a fairly in-depth interview of our overview of cap refill time in the management of sepsis, as well as an overview of the Andromeda Shock 2 study. And at kind of the end of all of the big things we talk about, we're going to try to integrate study results into our clinical practice as emergency physicians here in Manitoba. So let's start off with what is sepsis. So the new definitions here today are based on the sepsis, surviving sepsis 3 guidelines that came out a few years ago. So we'll talk about those definitions shortly in a minute. So that was last updated in 2016. So it seems fairly fresh, but was actually about 10 years ago. And this was a expert consensus kind of document that was considered sort of a landmark thing for medicine. Some of the highlights are that they removed the outdated Sears criteria due to poor sensitivity and specificity, despite them still showing up frequently on our EPR. And the term severe sepsis was actually deemed redundant. So what are the definitions? So first of all, what is sepsis? So the Sepsis 3 guidelines say that it's a life-threatening organ dysfunction caused by a dysregulated host response to infection. Next, we have septic shock, which is kind of a subset of sepsis where there's profound circulatory, cellular, and metabolic abnormalities with a higher risk of mortality than with sepsis alone. So this is something that's clinically important to us. It's identified by people with sepsis needing a vasopressor requirement to maintain a MAP of greater than 65 and have biochemically a lactate greater than 2 in the absence of hypovolemia. And finally, we have organ dysfunction, which is a part of these definitions, which we're going to talk quite a bit about today, which can be identified as an acute change in the total SOFA score or sequential organ failure assessment of equal or greater than 2 points that is considered due to the infection. So what is the SOFA score? So it's not something we really routinely use in emergency medicine. It's primarily designed for ICU level care, but it's something that's thrown around and I think can have some utility in medicine when we're sort of assessing and prognosticating for our patients. So the original SOFA score was developed in 1996, and it hasn't gone through any updates since. So just for context, it's older probably than some of our junior and senior residents in our program. So it's been around for a pretty long time. The SOFA score is designed to determine the level of organ dysfunction and risk of mortality in patients that are admitted to the ICU. So generally, patients are going to be scored at admission to ICU. They're going to get their initial score, and then every 24 hours. You can assess mortality based on the initial score or using the worst data point from their stay. And the 24-hour scores are calculated using the worst data points from the preceding 24 hours. Overall, this isn't designed to influence medical management, but rather is more of a prognostic tool that clinicians can use to determine sort of mortality risk and sort of severity of sepsis within their patients. So the SOFA score was designed by sort of an expert consensus in ICU level care. And they really looked at 6 primary domains to sort of determine what we need to assess to come up with this calculation. So they looked at cardiovascular, which was primarily derived through hypertension, renal, which looked at creatinine, their liver function, which was measured through bilirubin, respirations, which looked at sort of oxygenation metrics, CNS, which was primarily used through the GCS score, and then coagulation, which looked at level of platelets on blood work within patients. So just to sort of familiarize ourselves, if you haven't looked at it a while, this is what the SOFA score looks like. So for each domain, patients can get a score of 0 to 4, with 4, of course, being the worst. So for a total of 24 points. So you only need, remember, a score of greater than or equal than 2 to have sort of an increased risk of mortality. So fairly minimal on this score. When looking through the score, though, there's a couple things that might make it difficult to calculate, especially early on in admission, or if we're calculating it in the emergency department. So the first one is going to be the respirations. So this uses exclusively a PF ratio, so the PaO2 over FiO2, which means you have to have an art line and be able to do arterial blood gases fairly frequently to assess that. So that can be quite a hindrance. Also, kind of some glaring things that come out is that dopamine is the primary vasopressor of choice, which many of you know has gone out of fashion. I know I've been in emergency medicine for 5 years, and I don't think I've ever started anyone on dopamine. So it's fairly clinically irrelevant to me. And then throughout the table, there's just some really outdated practices, which is why I think the SOFA score needed to be updated. Uh, this is how you interpret the SOFA score. So it has basically percentage of mortality for initial and the highest scores throughout the patient's stay in the hospital, and pretty significant increases even with fairly low scores. So we use the cutoff of 2 to 3 to sort of identify increased risk of mortality. And a score of 2 brings you up from 0 to 6%, which is definitely not insignificant. And, if you're greater than 14 out of 24, you're, nearly 100% risk of mortality. So it actually is a good way to sort of characterize how severe the sepsis is, and what sort of the clinical course for patients might look like as they're staying in the hospital. So I kind of went over this a little bit already, but why did we have the need to develop SOFA2? So obviously, it hadn't been updated in 30 years. There's been a lot of changes in medical practice. So it was really just time for an update. So it's good that that got done. The initial SOFA score didn't take into account modern clinical practices, and sort of how patients are being cared for. The new SOFA also looked at more focus on organ support modalities, so things like dialysis, certain forms of respiration support, and other things that we use sort of routinely. And they also tried to look at if there was anything else that had, as you know, a potential signal for mortality. So the authors of SOFA2 and the consensus group actually assessed other potential organ systems. So they looked at both immune and gastrointestinal markers to see if there was an association with mortality in these patients. So going through sort of the SOFA2 guidelines and how they derived it, there was a lot of strengths that really popped out at me, that I thought made this actually like a fairly robust sort of clinical decision rule, and why we can use it. So first of all, they had an insane sample size. So they looked at over 3.3 million ICU patients through both their internal and external validation portions of the study and collected data over a time frame of nearly 10 years. So we don't really see too many studies that have millions of patients, and this one had over 3 million. So I thought that was quite impressive. The other thing that jumped out and, sort of makes it relevant, particularly to our Manitoba care, is that there is a really varied population. So this wasn't just coming from centers in Europe or centers in the States, where, there is sort of routine care and, less sick patients. But they actually looked at ICU data from over 1,300 ICUs from 9 countries around the world, from really variable social and economic demographics. So countries sort of Australia, Europe, looked at Nepal, European countries, the USA. So I think it did a good job at really incorporating and highlighting different social, economic, and kind of patient population backgrounds to really incorporate that into the studies to make sure they had a good sample and really varied population. The study also had really robust internal validation and external validation. So to create a good clinical decision rule, you need to have a derivation, you need to validate it, and then you need to implement the study. And their validation was really, really robust. So the internal validation kind of had 4 main cohorts with 2.1 million patients. They really randomized the the patients well and had persistent sort of variables across all metrics among all the cohorts that were analyzed. And they were able to look at the proposed GI variable measured at that time and realized that it didn't actually have an association with increased mortality. And the study authors decided to remove that from the SOFA2 score. There was also really strong external validation, a little bit less of a sample size, but still 1.2 million patients, once again with persistent variables among all cohorts. And in the external validation, they were able to show that each individual organ system within the new SOFA score actually had an increase in ICU mortality on its own instead of just points throughout the entire score. Finally, I think the study design was actually quite good. So they used a modified Delphi process, which I was not familiar with before looking into this. But in short, a Delphi process is a research technique where they essentially do surveys as a way of collecting data from respondents within their domain of expertise. They're really good for dealing with issues where there may be divergent opinions or where things may be controversial in order to achieve consensus concerning real-time and real-world knowledge on a specific topic. So for this case, they were looking at sepsis. So they had a panel of 60 intensivist experts, and they went through sort of a total of 3 rounds of these surveys and questionnaires. After each round, they sort of updated the information that came through from the previous round through a series of systematic reviews, and then were able to come through a consensus in that way. Because they were not able to reach a consensus and the data was not good on both the gastrointestinal and immune scores, they were removed from the final score through this process. So I just kind of want to highlight why I think this score is better and the update is good compared to the original SOFA score. So everything I'm going to show in the next few slides is going to be the updated scoring system, and I'll just go through kind of some of the highlights and changes and how it can be reflected in our clinical practice. So the big change from the cardiovascular is I highlighted before that dopamine was the primary vasopressor. So as you can see here, has been switched to norepinephrine, which is generally first line among all clinicians in the emergency and the ICU. In the previous iteration of the SOFA score, if you were on any norepinephrine, you got an automatic score of 3 points, which puts you pretty high into the scoring system. But now low-dose vasopressor only gets you a score of 0.2. I don't think we need to go into detail of how exactly everything works, but basically low, medium, and high-dose vasopressors are prognostic of increased mortality. And of note, vasopressors are only scored if they're administered as a continuous infusion for at least 1 hour. So, if someone's on norepinephrine for a few minutes, that doesn't count. It has to be, continuous over a time to be counted for this score. The next big change, and actually probably the most helpful, is going to be that of the respiratory domain. So previously, the SOFA score only used a PF ratio, which means you needed to get an ABG or have an ART line in place. But on this new updated score, you can actually use an SF ratio, which is calculated by dividing your SpO2 divided by your FiO2. Now, certainly there are some limitations to this because the FiO2, when someone isn't like intubated, can be somewhat difficult. But just kind of as a rough guideline, if someone is on nasal cannula, they get slightly more than room air, so about 22 to 24%. And every liter you add, you can roughly estimate about 4% for their FiO2 estimate. Oxymask is roughly the same, but once you're up to 15 liters, it's about 90% FiO2. And if you're on a non-rebreather, it's approximately 95%. So, you can incorporate these sort of estimations with the understanding that you're not going to get necessarily a truly accurate assessment, but it's something that's much easier to do, especially in the emergency department. The other benefit of this new score is the mention of advanced ventilatory support. So previously, this was not incorporated into the SOFA score, but now OptiFlow and high-flow nasal cannula are considered advanced ventilatory support now that they are more routinely used and are incorporated into this score. So it might give you a more accurate picture. The big change to the renal domain is the addition of urine output. So that's now available kind of for all points. So if you put a Foley in, that's something you can easily calculate. And the big thing is that this includes dialysis. So there was no metrics for any form of dialysis in the previous score. So now you get 4 points if you are receiving any form of dialysis, whether this is chronic or just continuous renal replacement therapy that has been initiated during your stay in hospital. To CNS, just some minor changes. So still uses GCS. But the big change is that it makes note of the use of need for drugs for delirium. So if you have a GCS score and having drugs for delirium, you can still use the SOFA score. It doesn't have to be purely GCS. And they also added some metrics to capture the score when GCS cannot be calculated. So looking at withdrawal flexion and response to pain, you can actually give points for that if you can't calculate a GCS accurately. The liver and coagulation metrics didn't change much, but just some slightly different values in the amounts of bilirubin or platelets. But I don't think we need to talk too much about that. When directly comparing the SOFA and SOFA2 scores, interestingly, patients actually generally scored overall lower scores in SOFA2 compared to SOFA1. So meaning that mortality, percentages are actually slightly lower when using the SOFA2 score, but felt to be slightly more accurate. Both studies had a similar predictive value. So just to a refresher, a predictive value is what establishes the relationship between a predictor and the criterion. So the test and the criterion is going to be the future outcome. Generally in statistics, a level of greater than 0.8 is going to be very, very good. Anything over 0.7 is considered acceptable. So the SOFA2 scored a 0.79, so very close to that very good sort of level. The authors also found in this study that a score increase in your SOFA2 of greater than or equal than 2 points ended up increasing your mortality during your ICU stay up to 40% versus 17% if you didn't have that score. So, a fairly significant jump, especially when you look at sort of those jumps in the previous SOFA score where it was about 6%. So importantly, I just want to talk about, how I might use this in my practice and some potential clinical takeaways. These are just my opinion basing regarding the research. They're certainly not evidence-based, but I think we have some points that we can use. So the study does not include pediatric populations, so it meant for adults with sepsis who are over 18. So that's kind of the first thing to note. And is initially designed for ICU patients meant for scoring at admission. So I'll talk about that in a second. And just one sort of other clinical pearl is that generally healthy patients without organ dysfunction prior to their sepsis should have a starting score of 0 because you remember you're looking at an increase in SOFA score. But if you have a hemodialysis patient, which obviously is prevalent in our population, they automatically get a 4 for renal. So if they end up with a score of 4, that doesn't indicate necessarily increased mortality. They would need to have a score of 6 in order to sort of be SOFA2 positive for mortality. The SOFA score or SOFA2 is not validated for use in the emergency department. And this is where I sort of think even though it's not validated, I think I may use SOFA2. So there's a number of situations where we have ICU type patients in our emergency department, whether it's, waiting for a bed because the units are full, waiting for transfer from a peripheral site. And, there's a lot of time spent in the emergency department, which sometimes is not the case in other centers where studies are being performed. So I do think it's reasonable to, this isn't meant to guide your medical treatment. It's for prognostication. So if you're having a discussion with family or, trying to think about how severe this infection is, it may be reasonable to calculate a SOFA2 score while they're in the emergency department, kind of as a surrogate for their admission score to ICU, because they would essentially be equivalent sort of based on timing from a lot of the things. So it's something that I might bring into practice, especially if I'm needing to have some difficult conversation and the patient has already been treated for a fair bit of time in the ED. So that's sort of all I've got on SOFA2. I next just want to go in kind of an overview of cap refill time in sepsis. So there's been a lot of evidence over the years and a lot of really good new evidence. And it's not something that I really use in my practice or see being used a lot. And it's something that's really that can be done. So I think it may have a lot of benefit to management of sepsis and septic shock in the emergency department. There's a number of landmark studies that have come out through the years. So we've all heard of early goal-directed therapy, the RIVER study in 2001. That was kind of one of the first big ones, but had significant limitations. Looked at heavily, it had cap refill as part of the metrics, but really focused on central venous sats, which is really difficult, and found to have a number of inherent flaws. So really has kind of fallen off by the wayside. A scoping review in 2020 found that cap refill time may not be great, as they found that significant heterogeneity exists in how cap refill time is measured, which makes sense if you think about like how you or one of your colleagues may measure. There's a lot of variability in how long you press, how long you look, the time you count. Like, do you use a stopwatch? Do you use your like to count out loud? So that does make sense. There is a lot of variability. But the real promising study was the Andromeda shock study of 2018, which looked at patients with early septic shock, does peripheral perfusion targeted resuscitation, so looking at cap refill, compared to sort of standard lactate clearance, improve all-cause mortality at 28 days. And while they found no difference in 28-day mortality, they did find that cap refill could be a potential metric in the future and needed more research. So that's where the Andromeda Shock 2 trials comes in. So the Andromeda Shock showed that cap refill is valid, as I already talked about. So Andromeda Shock 2 created something called personalized hemodynamic resuscitation, or PHR, which was a protocol which used cap refill time normalization as their target. So they developed a protocol and measured it, how successful it was using cap refill time. I compared their sort of trial against the standard of care based on sort of local guidelines and the participating centers, and looked at the outcomes of mortality, hospital length of stay, and length of time on vital support. Once again, fairly robust study done across 86 ICUs in 19 countries with about 1,500 patients analyzed. So a few things I liked about this study when I was going through it that I thought might make me want to use it in the future is that it had really good inclusion criteria. So adult patients with septic shock based on the Sepsis 3 definition, so really standardized. But what was really important is that these patients could be in the ICU, the ED, the ward, or OR. So many of these studies are really ICU based. So it's nice to see one that's actually generalizable to our emerged population. They developed a protocol that is really easy to follow. So I'll show you the flow sheets in a couple minutes, and they're really simple and really clear. So it's really easy to adhere to their protocol. And the interventions within the protocol are actually really simple. So this isn't something that needs to be done at a tertiary level center. It can be done at, rural, smaller hospitals, community hospitals. It doesn't require intensive monitoring. It doesn't require intensive blood work or labs. And I think could actually be followed by most physicians if you have any sort of resus training. So really anyone on this call, I think, would be able to follow their protocol, which was really nice to see. So we'll talk about the algorithm and sort of what they did, and then look at the protocol. So the important first part is to measure cap refill time. They used sort of a glass slide on the distal phalanx and held pressure for 10 seconds until the skin was, or held until the skin was blank, and then counted for 10 seconds. They then removed the slide and timed the cap refill time, which is definitely different than how I normally assess cap refill time, and probably most of us, where I just push on the finger for a few seconds and take a look. So I think important to kind of have that in the back of your mind. They base their treatment algorithm on kind of four fundamental pillars. So looking at cap refill time normalization as the target of hemodynamic resuscitation, so less focus kind of on blood pressure and lactate and things like that. They wanted to identify sort of hemodynamic patterns, so what was actually driving the hypotension and slow cap refill time, whether it's volume, sort of vasoplegia, or cardiac dysfunction. They wanted to have a focus on fluid responsiveness, so often measured using pulse pressure variation, change in velocity time integral after passive leg rating, but also mentioned that IVC assessment would be acceptable, and then some acute hemodynamic tests. Their control group was just usual care. So that was based on centers. It wasn't really mentioned too much in the study, but presumed to be sort of lactate clearance for most. And they did a cap refill time check at 0 and 6 hours. So they divided their treatment protocol into two tiers. So tier one, I really like. I think it's something that we can all do and actually, kind of focus and bring it into our practice if it's something we want to do. So the first thing they looked at was there abnormal cap refill time? Kind of yes or no. No, you don't need to do anything. Yes, you kind of move on to the next step. What I found interesting is that they used sort of pulse pressure as sort of the next step in the algorithm, which is something that can be really easily, readily done at the bedside and may actually change kind of your target because it can be sort of a surrogate for kind of volume status and whether or not patients need more fluid or not. So if the pulse pressure is found to be low or less than 40, you can assess for fluid responsiveness and give a fluid challenge up to a liter, which is probably kind of what most of us are doing anyways, but kind of skipping that pulse pressure check. If the pulse pressure is low, you take a look at the diastolic blood pressure. So if it's less than 50 and they have a normal pulse pressure, instead of giving fluids, you actually just give some norepinephrine for a target blood pressure of diastolic of greater than 50. Um, if these things are not working, and you kind of go down the pathway further, you move on to tier 2, which is a little bit more complex. The first step was to do a bedside echo to rule out cardiac dysfunction on echo. If no cardiac dysfunction and fluid responsive, give fluid challenges repeatedly. So 500 ml bolus is nonstop until cap refill time normalizes. If not fluid responsive, you go sort of through two different areas. So if they have previous hypertension, you may just assume that they actually may need a higher MAP goal. So you change your norepinephrine to have a MAP target of 80 to 85 for 1 hour. If after an hour your cap refill target is met, you stop or you maintain that norepinephrine. If not, you stop. The other route was to try an inotrope, so something like dobutamine, if they were failing all else. If you don't make it through these sort of treatments and still have a bad cap refill time, you go through rescue therapies, which were not specifically mentioned within the study. So tier 1, just we'll go back for a second, really simple. So really all you need is pulse pressure, a diastolic blood pressure, access to fluids, and access to norepinephrine, and you may be able to normalize, whereas tier 2 becomes a little bit more intensive. So what were the outcomes of this study? So the primary outcome was a hierarchical composite of mortality, vital support free days, and hospital length of stay, which was measured using a win ratio, which, as a refresher, is the number of pairs where the treatment patient has a better outcome, which is classified as a win, is divided by the number of pairs where the control patient has a better outcome. So basically, they match up every sort of arm of patients and compare them and see which one does better. And a ratio of greater than 1 represents a superior treatment. So in this case, we had a win ratio of 1.16. Some secondary outcomes showed that there's improvement in vital free support days, but there was no change in mortality or hospital length of stay on its own. So a change in the, sort of combined, but not necessarily an impact on mortality on itself. The protocol also had some impact on how we treat septic patients. So compared to usual care, there was overall lower volume of fluid administered to these patients. And at the end of time, compared to standard care, an overall lower lactate at the end of 6 hours when compared groups against each other. Few drawbacks to this study. So it's unblinded. So patients knew or providers knew what arm the patients were in. Cap refill time is subject to quite a lot of variability, as we already talked about before, so you don't know how accurately people are actually measuring it. The control group was not well defined, so it was usual care. So theoretically, patients in the control group could have been having the exact same treatments as those in the intervention group. So it may be a little murky on how different these groups actually were. And finally, because it used a hierarchical composite and, a protocol, it may be difficult to determine which portion of the protocol is beneficial. Is it, doing the fluid challenge? Is it doing the MAP test where you increase the norepinephrine to, target a higher MAP? Because it was kind of an all-in-one protocol, it may just be one portion of the protocol that's offering benefit and not actually the whole protocol on its own. Throughout the years, in the last 10 years, there's a lot of other studies that, show some benefit in cap refill as well. So I had a few here, but I'll maybe just skip over them in the benefit of time. But there's good evidence kind of throughout PEDS. There's a lot of RCTs. And if you want to take a further look, I'll provide them in my references for you all later. But basically, all of these showed some signal that cap refill time can be accurate and can be a good predictor for normalization of fluid status and improvement in potential sepsis mortality, and that it's readily available and accessible at the bedside. So probably most importantly, what are the clinical takeaways? So cap refill based on these studies can be valuable in the assessment of sepsis. So firstly, it's easy to perform. Any provider can do this, and you can do it at any time. It doesn't require pokes. It doesn't require blood work. It can be dynamic. You can check it every 10 minutes, and it's not, by any means time or resource intensive. So I think it's something that's kind of been forgotten that we can really, bring back and incorporate that's really, really easy. And it's great for low resource settings if, it's hard to get a blood gas or your iStat is broken, or you simply just don't have access to blood work or difficult blood draws. This is a surrogate marker that you can use to, figure out how your resuscitation is going before patients are being transferred. So I think it's clinically very useful. I really like tier one of the treatment protocol. So my plan is to actually take a look at things like the diastolic blood pressure as well as the um, pulse pressure in my septic patients or my patients with shock and consider whether or not these need fluids or whether or not these need pressors. Because we have a blood pressure, it takes 10 seconds to calculate the pulse pressure and is something that's really easy to do, and so not something I currently routinely do. And, as sort of to incorporate this in, I'm not prepared to get rid of lactate. I know that's the standard of care. And I will continue to trend lactates, as time when I'm resuscitating my patients. But I will actually bring in some cap refill time, in between these measures to see if things are heading in the right direction. Or if my patient has a deterioration, check a cap refill, and see how it's going while you're waiting for that lactate to come back. So I think kind of a blended approach of standard care and some of this new information, particularly from Andromeda Shock 2, will impact how I treat my patients with sepsis. And I think it's something that everyone here can take away as well. So before I go too much over time, I'll pause for questions, and I have my references up on the side there. So we have a question in the chat about from Omer. So about stocking glass slides in the ED or someone to donate shot glasses. I don't think it's so much the slide as long as you kind of have a flat, solid item. So even like a pair of scissors that are closed, the blade of a scalpel or something, as long as you're being safe, just so you can put sort of even pressure on that, on the end of the phalanx, just to really get, good pressure for a solid 10 seconds. That's not just your finger. Okay, well, if there's no other questions, I will leave it there and pass it on back to Rebecca.
Great. Thank you so much, Luke, for an excellent presentation. I may reach out to you as well to see if we can maybe get you to distill some of this into a bit of an infographic or something we could circulate or post, because I think this is very practical information that people can use, which is fantastic.
Okay, perfect. Thanks, everyone.
Yeah, thanks so much for speaking. We will just take a moment here to let our next presenters get their slides up on the screen. That looks great. I can see your slides. I'll introduce our next speakers, Dr. Hunter Goodon and Dr. Jess Ellis, both second-year residents in our Royal College Emergency Medicine program. Thank you both for speaking today. Their topic, as you can see there, relates to time to IV thrombolysis and ischemic stroke, and I will turn things over to them.
Okay. Hi, everybody. I'm Hunter. I'm one of the second-year residents in the program.
I'm Jessica, second-year resident also.
So the topic of the presentation today is going to be time to thrombolysis and ischemic stroke. The objectives of this talk, first, we're going to review evidence for intravenous thrombolysis for ischemic stroke within the current accepted time window of 4.5 hours. And then we're going to review and discuss some literature and some evidence for thrombolysis in an extended time window, so 4.5 to 24 hours after symptom onset. So first, just a little bit about reperfusion therapy and ischemic stroke. So there's two different types of reperfusion therapy that we use. There is thrombolysis, intravenous thrombolysis, and mechanical thrombectomy. Both of these treatments essentially try to establish the same thing, which is to restore blood flow to regions of the brain that are ischemic but are not yet infarcted. The long-term goal of these treatments is to reduce the disability and the mortality associated with ischemic stroke. So mechanical thrombectomy, essentially the indication for this treatment is patients need to present within 24 hours of stroke onset, and they need to have a causative acute occlusion, a large vessel occlusion in the anterior circulation. So they have to have an occlusion either of their ICA or the M1 branch of their MCA in order to be candidates for thrombectomy. There are significant limitations with this treatment in that the benefits are really uncertain for patients that have occlusions of other arteries, such as the ACA, the basilar arteries, the vertebrals, or the posterior circulation. These patients are typically not candidates for mechanical thrombectomy. Intravenous thrombolysis is the second type of reperfusion therapy. There are currently two proven effective options, that being alteplase and tenecteplase. Initial approval for intravenous thrombolysis came after the landmark 1995 NINS trial. Both tenecteplase and alteplase are currently FDA approved for treatment of ischemic stroke within 3 hours of onset. And again, this really came after the NINS trial in 1995. So essentially, this was it was a landmark study. It was actually consisted of two separate placebo-controlled randomized controlled trials, Part A and Part B, where they compared alteplase in ischemic stroke versus placebo. Essentially, the patients that were included in this study came in with ischemic stroke with a measurable neurologic deficit within 3 hours of symptom onset. They had many exclusion criteria for thrombolysis, for example, intracranial hemorrhage, recent stroke, recent GI bleeding. But they found that patients treated with IV alteplase, they had a 30% increase in favorable neurologic outcomes at 3 months. There was a safety concern in that patients also had a tenfold increase in symptomatic intracranial hemorrhage. However, there was no difference in mortality at 90 days, despite this increase in ICH. So after the NINS trial came out, there were multiple subsequent randomized control trials and meta-analyses that essentially demonstrated that tenecteplase and alteplase do have benefit in an extended time window. So this is 3 to 4.5 hours after symptom onset from an ischemic stroke. However, we do know from multiple studies, including a 2020 meta-analysis, that the benefit of intravenous thrombolysis continually decreases over time from symptom onset. So the longer you wait to give it, the less likely it is to have benefit. So for example, the 2020 meta-analysis essentially demonstrated in terms of favorable neurologic outcomes, a number needed to treat of 5 for 0 to 90 minutes, of 9 for 90 to 180 minutes, and of 15 for 180 to 270. We also know the risk of adverse outcomes, such as increased intracranial hemorrhage or mortality. Those adverse outcomes occur more frequently the longer you wait to give this medication. So the question of our presentation essentially is there any role for thrombolysis beyond the 4.5 hour symptom window for ischemic stroke? So there's been several RCTs published since 2018, essentially looking at intravenous thrombolysis after 4.5 hours. We're going to review 4 of the major trials that have come out over this time. Each of the 4 trials examines a slightly different patient population. So before we get into the trials, I do just want to touch on perfusion imaging. Because each of the trials that we're going to look at sort of hinge on this perfusion imaging. So essentially what this is you can do this either with the CT or an MRI. And the idea is that you give this contrast bullet or this contrast bolus intravenously, and then you kind of repeatedly assess the brain as the bolus is going through the brain. And essentially the idea is that you want to distinguish between irreversibly damaged and salvageable brain tissue to essentially identify patients that may have a high amount of salvageable brain tissue and may be good candidates for reperfusion therapy. This is in contrast to traditional CT angiography, in which essentially you're using contrast to visualize the actual arterial lumens within the brain, to visualize vessel occlusions. However, from what I understand is that both of these studies can be performed on modern CT scanners, and they can be performed as a single comprehensive stroke protocol. So the first trial we're going to look at is the Extend trial. This is one of the first RCTs that looked at thrombolysis in the extended time window. So this is a 2019 multi-center placebo-controlled RCT. It looked specifically at patients in the 4.5 to 9 hour time window, and it looked at alteplase versus placebo. So for this trial, there were sort of two different types of inclusion criteria they used. The first was clinical inclusion criteria. So patients that were included in this trial, like I said, presented with 4.5 to 9 hours after symptom onset. They also included patients that had wake-up strokes. And essentially, they defined time to symptom onset as being like the midpoint of sleep, essentially. The second different criteria they used was imaging criteria. So they used this CT or MRI perfusion study essentially to identify patients that had like a large amount of salvageable brain tissue and therefore would be good candidates for TPA. One important exclusion criteria for this trial was planned thrombectomy. So patients came in and they had a CTA that had like a large vessel occlusion, they may be a candidate for thrombectomy. Those patients were excluded from this trial. So this is a positive trial in that the primary outcome they looked at modified Rankin scale at 90 days. Essentially, a score of 0 to 1 indicates like excellent neurologic outcomes. And they found that TPA in this population, this patient population, was associated with improved neurologic outcomes. Again, they did find TPA was associated with a higher risk of intracranial hemorrhage. However, there was no difference in mortality at 90 days between the two groups. So the second trial we're going to talk about is the Timeless trial. So this was a double-blind, multi-center, placebo-controlled randomized control trial. This trial specifically was looking at tenecteplase versus placebo, included 458 patients. And this particular study was looking at the 4.5 to 24-hour time window. So again, this study used clinical inclusion criteria and imaging inclusion criteria. So the clinical criteria for this study, they looked at patients in the 4.5 to 24-hour window after symptom onset. But these patients had to have a large vessel occlusion as the cause of their stroke. So essentially, they had to have an occlusion of the ICA or the M1 or M2 branch of the MCA. In this trial, they included patients that were thrombectomy candidates. And again, the imaging criteria that they used for inclusion in this study was perfusion imaging, so CT or MRI to identify favorable candidates for TPA. So in this study, the majority of the patients who were included underwent thrombectomy. And typically, this was very quick. So this study was conducted at thrombectomy-capable centers. And essentially, the median time from when they gave the tenecteplase to the time when they did arterial puncture for the thrombectomy was only 15 minutes. So essentially, they gave the TPA, and then they just immediately did the thrombectomy. This was a negative trial. So this showed that there was no significant difference in the primary outcome, which was favorable neurologic outcomes at 90 days. So conclusions to draw from this study, essentially, there's no benefit to TPA in the 4.5 to 24-hour time window in these patients that have a large vessel occlusion and have immediate access to thrombectomy. This is essentially what this trial is demonstrating.
Okay, so for our third trial, we took a look at the TRACE-3 trial published in 2024. This was a multi-center RCT with open label, had 516 participants, and they looked at tenecteplase versus the standard of care. The outcome was excellent neurologic outcome. Again, the mean Rankin score of 0 to 1 at 90 days. The patient inclusion criteria was similar to the last, where they looked at large vessel occlusion of the M1, M2 of the MCA and the ICA, and again looked at the 4.5 to 24-hour window. They used the same CT MRI perfusion imaging, and used exclusion criteria, so different from the last trial, where they did not include anyone who had access to immediate thrombectomy. Okay, so the results of this trial showed that there was an improved neurologic outcome with those who had a large vessel occlusion in the 4.5 to 24-hour window with no access to immediate thrombectomy. So they had an excellent neurologic outcome. Although similar to the past studies, TPA was an increased risk for intracranial hemorrhage. However, there were no mortality differences at the 90-day mark. Okay, for our fourth and final trial, we took a look at the HOPE trial that was published in 2025. So again, multi-center RCT, open label blinded, with 372 participants. This one used alteplase versus the standard of care. And again, had the same primary outcome of excellent neurologic outcome, scored the same with the mean Rankin score. So patient inclusion criteria included, this is where things differ, any area in the brain for stroke level didn't need to be a large vessel, but did have the same time window of 4.5 to 24 hours window and included wake-up strokes. They used the same imaging criteria and excluded anyone who had a planned thrombectomy. Okay, so the results of this showed that alteplase could be safely administered beyond the 4.5 window, conventional window, up to 24 hours when salvable tissue is identified on the advanced imaging. Outcomes at the 90 days were statistically significant with treatment using alteplase compared to standard of care when using the mean Rankin scale of excellent neurologic outcome. So unfortunately, again, at the alteplase increased the risk of intracranial hemorrhage. Okay, so this is a summary of all four of our trials. So the Extend trial, again, just to briefly go over, showed a benefit at the 4.5 to 9-hour window with no planned thrombectomy. The Timeless trial was our negative trial that showed no benefit in the 4.5 to 24-hour window, and that specifically being in those with large vessel occlusions and also having immediate thrombectomy. The TRACE-3 trial showed a benefit at 4.5 to 24 hours in those who had a large vessel occlusion with no access to thrombectomy. And the HOPE trial showed a benefit at 4.5 to 24 hours with no planned thrombectomy.
Okay, so we're just going to look at some meta-analysis evidence. So there's a 2025 meta-analysis that included 8 randomized control trials, including the Extend, the TRACE-3, and the HOPE trial, and essentially included other trials looking at TPA in the 4.5 to 24-hour time window after symptom onset. Included trials looking at either tenecteplase or alteplase, with a total number of patients of 1,742. So this meta-analysis specifically included patients in that time window that did not have access to immediate thrombectomy. So it excluded the Timeless trial. Again, it used very similar imaging inclusion criteria as the previous RCTs that we've went over. 3 of the 8 studies included in this meta-analysis used perfusion imaging, either CT or MRI as imaging inclusion criteria. The remainder of the trials used something called DWI, flare mismatch on MRI, which essentially is just a different imaging method to identify favorable candidates for thrombolysis. So the meta-analysis showed that compared to standard medical therapy, TPA was associated with, number one, higher rates of excellent neurological outcome at 90 days. So again, they had more significant, they were more likely to have a modified Rankin score of 0 or 1. The thrombolysis in this patient population was associated with a higher rate of intracranial hemorrhage. But again, the meta-analysis showed that there is no difference in mortality in this patient population. And one thing that I thought that was important to take away from this meta-analysis was the imaging criteria that they used for patient selection. There was no significant difference whether or not these patients were selected for TPA with perfusion imaging, either CT or MRI, or this DWI flare mismatch. But there was a trend that patients that were selected with the perfusion imaging may have better outcomes. So the conclusions to draw from essentially our research and these trials are that in patients who meet imaging criteria based on perfusion imaging or DWI flare mismatch on MRI, data from multiple randomized control trials does support the use of TPA in the 4.5 to 24-hour time window, specifically when mechanical thrombectomy is not planned. In this patient population, the RCT data shows that thrombolysis is associated with improved neurologic outcomes with no significant difference in mortality. And I did want to touch quickly on the updated 2026 AHA ASA stroke guidelines. These actually just came out like last week. But there are two important updates with regards to thrombolysis in the extended time window. So first of all, the AHA is recommending perfusion imaging-based patient selection for TPA in patients in the 4.5 to 9-hour time window when thrombectomy is not planned. So essentially, these patients presenting 4.5 to 9 hours, no thrombectomy, perfusion imaging can be used to determine whether or not they might be good candidates for TPA. In patients in the 4.5 to 24-hour time window with large vessel occlusion and no access to immediate thrombectomy. So, for example, if they're in like a resource limited site or they're not able to get to a thrombectomy capable center in time, the AHA is recommending perfusion-based imaging selection for possible TPA, as again, it may have benefit in this particular patient population. I did just want to touch on a couple of the limitations of some of the studies that we looked at and the evidence on this topic. So first of all, most of the trials that we looked at, all of them actually were conducted predominantly or exclusively in China. So obviously different patient populations from what we see here in Winnipeg, North America. Secondly, it's pretty clear based on the data that the interaction between intravenous thrombolysis and thrombectomy in the extended time window is unclear. So thrombectomy currently is recommended for patients up to 24 hours, regardless whether or not they get TPA in the 4.5-hour time window. But whether to use TPA in the extended time window before thrombectomy is still unclear. So essentially, there's a little bit of an unclear role as to like what is the role of TPA in thrombectomy capable centers in the extended time window. The last major limitation is advanced imaging requirements. So in order to select for patients that may be candidates for TPA in the extended time window, it really relies on this perfusion imaging, the CT perfusion imaging. And the trials all had specific software programs that they use to identify salvageable tissue, which may be cost prohibitive. But again, from my understanding, there's no reason why the CT perfusion scans can't be done on modern CT scanners. And that's all we had. Any questions or?
I have a question, guys.
Yeah.
Seeing as I was around in 1995 when the NINDS trial came out, and it's ridiculous that that's keeps being used as a standard. So they were only able to prove a statistical difference at 90 days. Why
Yeah.
is that? It seems that thrombolysis should work quicker than that.
Yeah, I don't like you're talking why was the difference not?
Why does that continue to be used? We use the 90 days.
Yeah. Yeah,
What's the mean score?
Yeah, I'm not sure exactly like the 90-day like
It's
I
not your
don't know.
fault,
Yeah.
but it's a huge flaw in this entire research area, in my
Hmm.
opinion.
Yeah, yeah, can see that.
Yeah.
Just leaves, I
Hi to those who are still on the meeting. Apologies for the technical difficulty. Looks like Zoom crashed. We did have more than one person hosting the meeting, but it seemed to have ended the meeting for all. So my apologies. For those who are still here, I will put the evaluation link in the chat, and it will also be sent out by email. Thanks again for joining us today, and sorry for the technical difficulties at the end.